All right, thanks for sticking with us. I'm going to try to go quickly through some of the high points of these talks that I prepared for you guys. Some quick facts about workup of the adult neck mass. I think the key take-home point is to think cancer, or think cancer until proven otherwise. So a persistent neck mass in an adult is usually a neoplasm, and so it's malignant until proven otherwise. And it's important to recognize that risk factors for head and neck cancer are changing, and that there's been a decrease in smoking rates and a rising incidence of HPV-related malignancy. So a lot of people with head and neck cancer these days are younger, non-smokers, higher education, socioeconomic levels, and have never been sick in their life. And it's also important for the primary care doctor to realize that delays in diagnosis are quite common and unfortunately do result in worse outcomes. So some normal neck anatomy. This is just a reminder of kind of some of the ways that we communicate the level of a neck mass, and it's helpful in forming a differential and also in understanding the pathology reports on some of our cases. So I don't know if you can see my mouse. Looks like you can. So, level 2 is kind of the high part of the neck. Level 3 is the mid part, and level 4 goes all the way down. Level 5 is the posterior neck, where a lot of skin cancers will metastasize to. Level 6 is the central neck, where a lot of thyroid cancers will produce nodes. And level 1 is right underneath the chin, more likely to come from an oral cavity site. But the kind of major drainage of the head and neck is kind of in levels 2, 3, and 4. So that is sort of where tumors from a lot of different areas can go because of so many lymph nodes being present. I'm going to quickly review some of the guidelines. So this is probably the most important slide. So whenever a patient comes in with a painless, enlarged neck mass that's been there for a few weeks, don't give an empiric trial of antibiotics. This is the first point in the guidelines, and it's something that, I hate to say that you'll see even ENTs do sometimes. Someone comes in, I had a patient who came in with a fairly advanced tumor, and they were upset because their first ENT, gave them ciprofloxacin. And several weeks went by before they got an appropriate biopsy. But between 20 to 70% of patients in some studies report that delay is caused by a trial of antibiotics. If you do give an antibiotic trial, you think it may be an infection, do reassess them within 2 weeks. However, if a patient has reactive lymphadenopathy, you typically don't need to treat this with antibiotics. So we all should recognize what's called a standalone suspicious history. The patient comes in, they tell you this, the alarm bells ring. So this has been going on for at least 2 weeks. They've had no recent infection or dental problems. They have a significant smoking history, and the mass has not fluctuated in size or it's continued to grow. This standalone suspicious physical exam is this. If your patient walks in with this, they need a CT scan. So, the mass appears to be greater than 1.5 centimeters. It's firm. It may or may not be fixed to surrounding tissues, but if it is, that's very bad news, and it's non-tender. What should you do for these patients? We're going to go through the kind of next steps. So think of referrals in certain cases. So, any of us here can perform a laryngoscopy for your patients. This is particularly important if you think that if the patient has any hoarseness or throat symptoms, or if you think there could be a tongue-based mass, this is the best way to assess for that. Or urgently, same day, if the patient is having any type of airway concern. You can perform or refer for a thorough oral cavity or oropharyngeal exam. If you think it could be skin cancer related, they may need a dermatology lookover, and you can refer them for a thyroid ultrasound if the mass seems to be associated with thyroid mass. Another key slide is, and this is untimely because of our shortage of contrast, but the key study to get for most adults with a suspicious neck mass, suspicious for cancer, is a CT or MRI with contrast. The CT is usually what I go for because it's more expeditious and cheaper. These days, maybe not because of the contrast shortage, but this does a number of things. It characterizes the neck mass and it evaluates for possible primary spots. If you look in their mouth, you don't see anything, you at least get images of their throat all the way down. And this is important for staging the patient as well. Generally good to avoid non-contrast studies during normal times. And if you do have to go non-contrast, an MRI is a better study than a CT. And then the other key step is is you can order an ultrasound-guided FNA. In the head and neck, we skip a lot of the labs and we go straight to a tissue diagnosis because the masses are accessible. So this can be either surgeon or radiologist performed. It's generally a low-risk procedure with a high accuracy. We generally don't perform open biopsies for suspicious neck masses. The only real contraindications to an FNA is if you think it could be the carotid or something like that, which is pretty rare. Another key point is that in generations past, a cystic neck mass was regarded as generally benign. We talked a little bit about HPV tumors. These days, they tend to produce cystic neck nodes. So historically, they said, it's a isolated cystic mass in the lateral neck. Could be a branchial cleft cyst. These days, you have to be very suspicious. It could be an occult metastasis from the tonsil. So if a person comes in, they have a fluctuating neck mass or a CT scan that shows that, you can refer them for a focused exam. If they don't have one, they need a CT neck with contrast, and you can send them for an ultrasound-guided FNA biopsy. The ultrasound-guided is important because they can target the capsule of the node and avoid the kind of necrotic middle part, which will not give you a diagnosis. There are some ancillary tests that are useful when an FNA is not diagnostic, and this is sort of the list of them. But the key point is really that these ancillary tests, are not necessary in most cases, and are secondary to establishing a tissue diagnosis. That's the differential. I'm going to skip through some of my slides about HPV because of time considerations and give you guys a quick update on thyroid cancer. So this is really going to be some just key take-home points about thyroid cancer. So the kind of watershed year in thyroid cancer came with the latest edition of the ATA, or American Thyroid Association, guidelines for management of adult thyroid nodules, where a lot of things changed. And the key points, which probably everyone is familiar with and have generally been assimilated into practice in the last 7 years, is that they generally advised against biopsy of any suspicious thyroid nodules that were less than a centimeter in size. And the big shift for a surgeon was that they promoted a hemithyroidectomy for low-risk cancer. So previously, someone came in with a 1 centimeter papillary thyroid cancer. They get their whole thyroid out, no questions asked. These days, most of those patients are going to get a hemithyroidectomy. It generally brought about less liberal use of radioactive iodine, and also required less intense surveillance from endocrinologists after surgery. So again, key points. So another key point: what's new in what's new in thyroid cancer? The concept of active surveillance. This is a paper that I wrote up in the last couple of years, kind of summarizing this. But recently, there's been what's considered an epidemic of small, low-risk thyroid cancers because of the proliferation of kind of ultrasound screening tests. And this has kind of uncovered this large subclinical reservoir of disease that generally doesn't advance or cause problems. And this is a disease that has a 97% 10-year disease-specific survival when treated with surgery. So active surveillance is basically a joint decision between a patient and a clinician to closely monitor a known cancer that is thought to be low risk, and it's monitored every 6 months for growth, with the understanding that you're choosing someone that, were the nodule to grow, or even if it were to spread to a central lymph node, that the outcome would be the same as if you were to treat that lesion up front with surgery. So it's been studying a lot of clinical trials, which I'll get to. There's some advantages and disadvantages. So the advantages is obviously you avoid surgical risk of nerve paralysis, calcium problems, scarring is a major consideration in many of the countries that did the clinical trials, and the problems of having surgery. But I think the last point is the most interesting, is it addresses the fact that we believe there's a large subclinical reservoir of kind of low-risk disease that's out there and never discovered. And it addresses the concerns that we're over-treating thyroid cancers by operating on all the small, low-risk ones. The disadvantage are many. So there's, the patient has to stick with the program and not forget about it. There's, long cost of, follow-up monitoring that's needed. There's a theoretical risk of cancer spread, and that's closely related to the patient anxiety of having a small cancer that is in your neck that you're not going to treat. And so not all patients are appropriate for active surveillance for this risk. And it's a less definitive way to deal with the problem. So that is kind of in a nutshell. So there's a lot of clinical trials that have been done, mostly in Asia, some in North America. There was a recent meta-analysis that looked at 4,000 patients that have been enrolled, and basically the results you could say are comparable to surgery. So in these studies, about 4.4% of the time the tumor grew and required intervention. About 1% of the time there was a lymph node metastasis that developed, and a very small percent, 0.4, developed metastatic disease. To my knowledge, there's been no deaths in any patient enrolled in active surveillance trial. Switching gears again, so medullary thyroid carcinoma, rare thyroid cancer, only 2% of thyroid cancers, but it accounts for about 15% of deaths from thyroid cancer. Things that we learned in medical school, 80% are sporadic, 20% are hereditary, and 50 to 60% of sporadic tumors, which are going to be many of your adult patients that come in, are going to carry a RET mutation. The M918T mutation is the most common and also is associated with more aggressive disease. And so all patients with medullary thyroid carcinoma require germline testing to determine is this a hereditary condition or a somatic sporadic mutation. And all patients receive calcitonin and CEA as part of their kind of staging. And if the patient has very high levels of these, they can actually cause systemic symptoms of flushing and diarrhea. Many of these patients present with more advanced disease, as medullary thyroid carcinoma has a tendency to spread to lymph nodes. The workup is mostly similar to differentiated thyroid cancer, except for they're going to get an ultrasound of the neck, you're going to send them for an FNA biopsy, but they're going to require serum calcitonin and CEA. Surgery is still the preferred treatment when the patient is curable for local and regional disease. When a patient has a very high calcitonin level above 500, that should prompt metastatic workup. And the reason I'm talking about this today is that there's new systemic treatment options that are available. So these include multi-target kinase inhibitors or super-selective RET inhibitors, which are recently approved and which I'll talk more about. And so these are not for small curable tumors, but for very locally advanced or recurrent tumors, or those with proven metastatic disease. Medullary thyroid carcinoma is not a differentiated cancer, and so there's no role for radioactive iodine treatment and a very limited role for radiation. So selective RET inhibition, so there's two drugs that have been FDA approved, selpercatinib or praseltinib, are both approved selective RET inhibitors. They have pretty good response rates. 2/3 to 3/4 of patients will have a response, and the majority of them are durable, somewhere around 80% in the trials that have been published. And these super selective inhibitors are better tolerated than the non-selective multi-target kinase inhibitors. So that was fast. And our next and final topic is anaplastic thyroid carcinoma. So we all know about this. It's a very aggressive thyroid cancer with a very poor prognosis. And these patients present with aggressive, fast-growing central neck mass. And oftentimes they have tracheoesophageal invasion, and they have a tendency to also have distant metastases. Historically, the survival was only about 6 months for these patients. But there's been a change in recent years. Many of them actually carry a BRAF mutation in about 50 to 60% of cases. And BRAF MEK inhibition has resulted in dramatic change in outcomes. And the computer looks like it's about to die. So I don't know if there is a plug up here, but we should probably get one. So there's new targeted therapy for DT or dabrafenib, trametinib, has been FDA approved for only about 2 years, and so this requires the patient to have a V600E BRAF mutation. So the workup of these patients is now very multidisciplinary. It's no longer just a surgeon rushing off to surgery. The patient, they have an airway evaluation. They get a core thyroid biopsy, and the pathologists are in a rush to do immunohistochemistry to confirm their mutational status. If they have a BRAF mutation, unless they are, eminently resectable, then that's probably going to be their first step, and it results in sometimes dramatic and sustained responses. And the current practice is to reassess them for surgery if they have a significant response, because not all of them will have a lasting response. So this is pretty much what we covered. I think the other key thing is the trend away from performing a trach. In these cases, historically, these patients would get a trach for palliation, but it's now generally avoided because it's considered to be, to kind of prolong a death that's very unpleasant. And so in most cases, I mean, palliative care discussions are part of the workup, and usually that means avoiding a tracheostomy. So that was a bit rushed, but thanks everybody. If there's any questions, happy to answer.